Good morning, good evening, good night. Welcome to WSPOS webinar. Somebody once said, how many times do I have to teach you? Just because something works doesn't mean it can't be improved. And today we're going to try and improve what we do with simultaneous Spanish translation. During the webinar, as we find out where people are listening from, we will change the language, but I will be the only one doing this because this is the first time we've ever done this. So welcome to Worldwide Webinar WSPOS 14 Aniridia. My name is Ken Nischel, and it's my great pleasure to co-moderate this with Dominique Bremoniac. We have an absolutely superb panel, but before we get there, I want you to know that the WSPOS channel on YouTube has some light entertainment for you. We have an amazing piece of sitar music played by Akila Acharya. We've got 2 donate videos, one of them spoken in different languages, one of them spoken in English, but with different accents. We also have a small video about WW Connect, and it's made up of pictures sent into our WSPOS Facebook page, and I'd really like you to look at these. They'll give you a light relief between all the hard work you're doing on these webinar listening sessions. I need to mention once again that the Worldwide Connect 2020, which is the virtual WCPOS, is going to be announced with its full details. This is something that has never been done before. Similar to the simultaneous translation that you're seeing right now, we want to try new ideas to innovate. And on that point, I want to thank everybody for working with us together. So before we go any further, this is the QR code. This is the Menti code, 408437. I repeat, 408437. Go to menti.com, and there are going to be some questions coming up right now. Please try and answer them. Let's be interactive. Let's do this together. So the Menti questions are coming up. What can I say about David Walton? He is a mentor of mine. I have followed his work. He devoted his career to providing improving care for children with glaucoma. He studied engineering at Haverford College, medicine at Duke, residency in pediatric at Boston Children's, his residency in ophthalmology at Massachusetts Eye and Ear Institute. He founded the Children's Glaucoma Foundation with the assistance of dedicated parents of affected children. David, you're a mentor, and it's an absolute pleasure to have you on board today. What can I say about Dominique Bremoniac? Born in Paris, France, professor of ophthalmology, head of department at the Necker University Hospital for Sick Children in Paris, and the head of the Opthara Rare Eye Diseases Center. Last year, I was lucky enough to visit her. She has an enormous cohort of children with Aniridia. And what I learned in a day, I tell you, was absolutely astonishing. So, Dominique, a pleasure to have you, as always, as a co-moderator. Menti questions 4, 5, and 6 are going to be put up, and I'm going to hand it over now to Dominique. Dominique, all yours.
Okay, thanks. So, welcome to everybody. And it's a real pleasure to have you on board for this webinar 14 for Aniridia. And first, my really good friend, very good friend, Dr. Ken Nischel, MD, FAAP, FCRO, and so born in Nairobi, Kenya, and in England, and also working in Pittsburgh, professor of ophthalmology, University of Pittsburgh Medical Surgical Division Chief, and also for Children's Hospital of Pittsburgh, Medical Director of Digital Hospital UPMC Children. So he is absolutely tremendous because all of these could be done with him. and also he's vice chair quality UPMC Eye Center. So that's the first luck we have to have him with us. And next we have also Neil Lagali, another friend, and he is absolutely very keen in Aniridia. He's born and raised in Canada, lived in and worked in Canada, US, Netherlands, and Sweden, and completed doctoral studies in engineering in Canada in 2000. Thesis in light and optics, changed field of biomedical research with special interest in the corneal imaging, angiogenesis, and regenerative medicine. He is also professor in experimental ophthalmology, Faculty of Medicine in Linköping University in Sweden, and he has been living in Sweden the past 13 years. He has a great interest, as me, in Aniridia and its effect on cornea as keratopathy. He performed detailed corneal imaging in Aniridia cohorts in Sweden, in Norway, in Poland, in Germany. And he is working closely with Aniridia Patients and Association. Of course, we work together because we work in Aniridia Europe Association for the scientific committee, and also as I work in my country with Generis. And he is chair of the European Union Cost Network Aniridia Net, comprising of 200 members across 28 countries. And I'm really very happy to cooperate with him in this great project, Cost European project. And the last I have to introduce is Anna Skanga. Hannah is a real pleasure because she is licensed in genetic counselor and by American Board of Genetic Counseling. She earned a Bachelor of Science and in Molecular Biology in Westminster College in New Wilmington, Pennsylvania, USA, and a Master of Degree of Science degree from Genetic Counseling Program at Case and Reserve University in Cleveland in USA. She has a great experience in both both of these academic and industry setting, dedicating majority of her career to ophthalmic genetics at UPMC Children's Hospital in Pittsburgh. So this is really great. And I just would like to introduce Anna for her talk. And she will tell what you do when you see a baby with Aniridia and what is a genetic counselor view. So thank you, Hannah. It's all yours.
Anna, while you're sharing, I just want to tell everybody, I'm getting lots of messages. We have Indonesia, Baghdad, Pakistan, Sweden, South Africa, Argentina, Philippines, Bahrain, Lebanon, Chile, I said Argentina, Brazil, Philadelphia, that's in the USA, Venezuela, so Singapore, Oman. It's truly international. Take it away, Hannah.
Thank you, and thank you for the kind introduction. I'm glad to be back. So today, in just a few minutes' time, I'm going to discuss with you my view whenever we see babies with Aniridia. So of course, genetic counseling is a big component, and I'll touch on each of these 4 areas today. And I'll leave a majority of the signs and symptoms to Dr. Bremont-Genac when she gives her presentation to discuss the spectrum of Aniridia. But for the focus of mine, I'm really thinking about children who have near complete Aniridia, because these are the ones we have to be more concerned about that may have a larger syndrome. But here is a list of the symptoms you may see in children with Aniridia across the spectrum of the disease. One thing I really focus on is the systemic involvement. Now, in an infant, of course, very difficult, but as the children age, these may emerge. The one risk we really must think about, even in infancy, is the risk for Wilms tumor. The children with near complete or complete Aniridia may have a chromosomal defect that puts them at risk, and I will discuss that with you today. But we may see these other features in children and adults as they age. Family history becomes important when we think about aniridia. So getting that pedigree, looking for, is it sporadic in the family? Or when we do find the isolated cases, it can be highly familial. So again, a theme we've seen in these webinars of genetics is looking at parents, looking at family members. This again remains important in aniridia. And the children that may have Wagner syndrome or Wilms tumor aniridia and the genitourinary abnormalities and developmental delay or intellectual disabilities, they often have this due to a de novo or spontaneous chromosomal deletion, which I'll discuss next. While we believe that this is usually spontaneous and not inherited, there are questions of, could parents have some mosaicism where they may actually have the deletion in some of the reproductive cells that actually increase the risk. But this does remain a rare possibility. When we think about genetic testing, we're talking about chromosome number 11, specifically a region called 11p13. And I have another slide here to show you as we get more granular to look at the molecular structure. When we think about PAX6, which is the gene that causes more than 90% of cases of aniridia, we must think about its genetic location and what's nearby. And so the WT1 gene is a predisposition gene for Wilms tumor, which is the most frequent renal tumor in children, but they can be at a very high risk of developing this if they have aniridia when the chromosomal region of PAX6 is affected. If they have a large deletion that takes away PAX6 and causes aniridia, that same deletion can take the nearby gene WT1, and that is really where this risk becomes high. So we have to think about, how do we screen these children? If WT1 is involved, their risk to develop a Wilms tumor, depending on the literature, ranges from 45% to up to 77%. Now, this is an infantile and childhood tumor, so it is age dependent, but we still must screen them because this can be a very fast-growing tumor. In fact, when we diagnose a child with aniridia in our clinic, if we feel that it is complete or partial, there's a risk for Wagner, we actually do not let them leave our facility without getting a renal ultrasound to be sure we're not sending them home already with a growing tumor. So we must consider screening if WT1 is involved, or if you were unable to get a genetic test, but the aniridia is partial or complete, and this is a concern, renal ultrasound every 3 months and surveillance by a pediatric oncologist would be your safest approach. We must continue this up until the age of 8 because, as you can see here, the age-related risk for children who do go on to develop the Wilms tumor, 90% of them will have it by the age of 4 and 98% will have it by the age of 8. So that's the reason for that spectrum. We do have 2 forms of genetic testing. The chromosomal microarray will detect your deletion to be sure WT1 is or is not involved. And our sequencing and deletion duplication studies allow us to interrogate PAX6 alone and look for variants inside of it that could cause aniridia and know that WT1 is not included. And on the second presentation in this webinar, I'll discuss how this part of the testing becomes relevant for your patients. Thank you.
Thank you so much, Hannah. So take that on board, because what Hannah's going to talk about towards the end really is very important for what's happening in the future. So it gives me great pleasure now to introduce Dominique Bremont-Gignac. Dominique, take it away. I'm really looking forward to hearing your talk. While Dominique unmutes, I just want to say we have Spain, France, UK, Algeria, Nigeria, Colombia, Portugal. Okay, all yours, Dominique.
Okay, that's great. Thank you very much for all these countries just listening to us. And thank you, Ken, because we will see that varied phenotype of PAX6 mutation is really wide. And of course, we know that it's a rare disease, congenital, and the epidemiology can be varying about the region. It's a real panocular disease, but when you say aniridia, you think that every aniridia has an absence or anomaly of iris, and that's the question. So it can be also systemic associated anomalies like diabetes, hyperosmia, hearing loss, and brain anomalies as Anna said, and genetic mutation is essentially PAX6, but not only. And we have syndromic aniridia, as we can see. And of course, the classical is aniridia model, and it could be the complete aniridia on the left or the partial aniridia, as you can see here, with a root of iris. And all of these ocular anomalies can be observed in aniridia, as you can see on this anatomic eye, and I will detail that. But the problem is just a quiz. The quiz is, can you tell do you think that in congenital aniridia, ocular examination can be without iris anomaly? You can see here normal pupil and normal iris. But the other eye is different. It's pseudo iris coloboma and iris anomaly. And the question is, of course, you can have a normal iris or similar normal and can be PAX6 mutation. So we have those phenotypes here, as you can see here. But you have also the Gillespie syndrome. As you can see, the iris anomalies is a little different. It's a large iris root, regular, which is different from PAX6 anomalies. So aniridia variable phenotype. You can see here the mother. So she was a mother, and she was told when she was young that it was only coloboma. But this coloboma, it's very strange, but not in the center, not actual. And when you see the child, here the daughter, and you see this is a complete aniridia bilateral. And this is very important because, of course, the prognosis is very different. It could be also congenital glaucoma, PAX6 mutation, and David will probably detail that widely, so I will not tell more about that. It could be also congenital cataract. It could be sporadic family cataracts with crystalline mutation in some, but it could be also syndromic cataract. But also you can see both of them is cataract in PAX6 mutation, as cartwheel and in the other subcapsular anterior. In these families, you have also cataracts, and you see on the right a mother with both aphakic but quite normal iris, but also macular hypoplasia. And you see on the left two special iris, but could be interpreted as normal. So this is very important to know that. Also in PAX6 mutation, there is also lens anomaly. Here you can see here the lenticonus, posterior lenticonus, and in the under photo you have a coloboma of the lens. And last possibility could be anterior dysgenesia with Peters anomaly. I know, Ken, you don't like this term, but in this family, this child has a PAX6 mutation also, and you can see here the anterior dysgenesia. So you can see all this panel could be very wide, and association representing the disease at the national level as generis of the reference is our center in Italy, in Spain, of course, in most of other European countries, and also at the European level with Aniridia Europe and the cost action we have talked about and Neil will tell about. So in conclusion, aniridia PAX6 mutation may be with a normal iris. Congenital cataract may be only due to PAX6 mutation. Peters anomaly may be also due to PAX6. Thank you for your attention. Thank you very much for.
Thank you so much. If I can get everybody to unmute, because we're going to have a discussion now. Both of those talks were fantastic. I'm just going to go through the Menti questions. So the first Menti question was, what is your age? And it looks like 58% of people listening are under the age of 50. And then the next one was, what is your sex? And 74% are female. So that's fantastic. Then the third question, PAX6 related aniridia can be inherited as autosomal dominant, autosomal recessive, or X-linked recessive. 63% said dominant, 33% said recessive, and 4% said X-linked recessive. So I'm going to ask Neil and Hannah, can you address that? Can PAX6-related aniridia be autosomal recessive?
I'll let Hannah answer that.
Sure. So PAX6 related aniridia is an autosomal dominant trait, whether it is inherited as a mutation within the PAX6 gene or in the case where you do get a chromosomal abnormality, because they are only going to pass on one of the chromosomes which have it. There sometimes can be some confusion if we start to bridge the idea of what we call phenocopies or other genetic eye conditions that can feature what looks like aniridia. Those can be inherited in another way, like recessive traits. So we have to be careful about our genetic testing to prove, but PAX6 related aniridia is dominant.
So let's just take on board what Dominique was saying. Dominique, there's a question coming from Facebook. It says, my concern is the foveal hyperplasia. How can I pick up foveal hyperplasia before, for example, cataract operation or glaucoma operation? What do you do? How do you do that?
Well, the problem, you can't do that because the opacification does not allow to have an OCT. And so that's a problem because you have to discuss with the parents because, of course, when you operate a congenital cataract with PAX6 mutation, usually there is macular hyperplasia, so the prognosis is very different. And so as soon as it's operated, I do under general examination and I do a OCT intraoperative to be sure there is a macula or not. That's the possibility. And also when you have the possibility to do genetic examination, genetic perspective, of course, you will know if it's a PAX6 mutation or not.
So I want to ask David Walton, I have seen patients who have PAX6 related aniridia, but they have intact iris. Have you dealt with any of those cases where they've had glaucoma?
Well, we've seen beautiful pictures of this variation of the iris hyperplasia presented by Dominic, and it's unusual, but it does occur. And when the iris is more intact, as a general rule, the disease is expressing itself more mildly, and they're not so much at risk for glaucoma.
And I have to agree, that's my experience. Dominique, what's your experience?
About glaucoma, you mean?
When the iris is present, like the ones that you showed.
Okay. Well, the problem is very, very usually there is a problem of diagnosis. So usually they don't know about, and so they don't know why there is not a good recovering of visual acuity. And so it takes a long time. And of course, the problem is when the babies come after, because the mother don't know why, but doesn't know why. But after, when the babies come, there is sometimes a complete aniridia, for instance, and the diagnosis is made, but later with a delay. That's a problem.
But do you see glaucoma in the ones where you have the iris present?
I haven't seen I think glaucoma in aniridia, I mean congenital glaucoma in aniridia is very unusual, and I've never seen congenital glaucoma with iris with PAX6 mutation, but it doesn't mean that it does not exist.
No, of course. Neil, we're going to listen to your talk, very interesting talk about keratopathy. Have you come across patients whose iris is present, they have a PAX6 mutation, do they get keratopathy?
Yes, we have come across some cases with almost complete iris present with PAX6 mutation. However, we tend to see in those cases that the keratopathy is very difficult to detect, or it's very mild in those cases. So it's not,
not very.
No, I agree. I agree. And so let's put it another way. How do you pick up? Because we expect, when we talk about aniridia, no iris or an iris stump. We expect the classical pictures of the anterior and the posterior cataract, then the nystagmus, and you expect the foveal hyperplasia, and sometimes optic nerve hyperplasia. How do you suspect somebody who has an intact iris may have PAX6 mutation? Dominique, any clues, any hints?
Well, I think that the clue is if you can do an OCT as soon as possible, you may suspect a PAX6 mutation because there is macular hypoplasia. I think that's the most important sign to find out. And if I should say, if the macula is normal, so it's probably not a PAX6 mutation. I think that's a clue when you would just want to do that. The problem is not very easy to get an OCT in young children because you need to do that under general anesthesia with a portable. Well, it could be done by this handheld OCT, but it's not everybody that can have access to it.
And do you think? Have you ever seen, has anybody ever seen PAX6 related aniridia with or without iris where they have foveal hyperplasia but no nystagmus? Have you ever seen foveal hyperplasia, no nystagmus? Has anyone seen that?
Yes, I can answer because I've seen that. I've seen no nystagmus and I can't explain it. Even maybe it's not the grade 4, but I've seen no nystagmus with hypoplasia, macular hypoplasia. That's right.
I've never seen that. I have never seen that. I've always seen nystagmus when there's foveal hypoplasia.
Well, that's a good sign. All right.
Right. Okay. All right. Well, we have some other questions coming in, and we have people. Is there a possibility of aniridia without foveal hyperplasia? Let's put that to Neil and then Hannah. Is it possible to have aniridia without foveal hyperplasia? I think that might be a trick question in some ways.
Yeah, so we've seen a range actually of Dominique had mentioned the grading of the foveal hypoplasia. We've seen a range of grading of hypoplasia in aniridia, and even some that have quite a well-defined foveal pit. So yes, it is possible, and those are cases of confirmed PAX6 aniridia. So yes, it definitely is possible.
So Hannah, we've seen cases where they have no iris whatsoever, but they have a fovea and they have no nystagmus. What do you think about then when you see that as a genetic counselor?
I still want to pursue all of the testing because I think some of this, basis of the trick question too comes back to aniridia just being that panocular disorder that, right. There can be variable expressivity throughout the eye and between the eyes. And I think that that's where some of these tricks may lie in getting to the diagnosis. Because you don't have to have the checklist of features that we're thinking about. And, regardless, when there is partial or complete aniridia, PAX6 is always at the top of my list, thinking about the genetic cause because that's the most common cause.
So let me add to the mix. David, if you saw a baby with no iris in either eye, no nystagmus, and they had posterior embryotoxon, 360 posterior embryotoxon, what are you thinking now? So there's no iris, there's aniridia, no nystagmus, and they've got posterior embryotoxon for 360. Does that change your approach, your thinking?
Yeah, we've been talking here for a bit about the really unusual expressions of aniridia, and that's of some interest. But of course, the typical case, and that's most of them, aniridia is a variable disease. It expresses itself variably in all the tissues. I've not encountered any patients with aniridia who have normal acuity, but some have quite good in the 20/50, 20/60 range, and they undoubtedly have some fovea. unfortunately, the fovea is not a very reliable diagnostic tissue to really appraise, but there is a very specific corneal defect for aniridia, and it's not very pronounced in a young child, but it's essentially always there, and that's that peripheral pacification of the epithelium. It's helpful to put a little fluorescein in. I don't think that's cheating, but you put a little fluorescein in, and it stains very vividly. It's typically quite mild and has a sort of coast of Maine characteristic along its inner border, but that's the diagnostic sign in these unusual presentations that you really look for to make the diagnosis of hereditary aniridia. And if I had the patient as you described with this visible Schwabi's line, I would not think that's really characteristic of aniridia, and I'd be highly suspect that aniridia exists.
Yeah, so the reason why I bring this up is that I had a patient sent to me exactly the same as I described, and actually turned out to have a FOXC1 deletion. So there are other causes of aniridia, iris not being present, and the presence of a posterior embryotoxon really makes me think more of Axenfeld-Rieger kind of anomaly. Would the panel agree? I mean, am I out there on my own?
That's a very good point, Ken, because it was a tricky question, because the tricky question is when something is disrupted, I mean, you don't have a complete panel of the aniridia, you should think about another gene. And so that's true. When you have embryotoxin, you can think about FOXC1. And also when you have congenital glaucoma, you can think about FOXC1. So this is a tricky question because we don't know exactly if it's aniridia with Paxec mutation or aniridia and not complete aniridia, and so we have to look more about other genes. So that's why it's very important to see, of course, the phenotype, but to confirm also by the genotype, because with a different genotype, you can probably suspect a different genotype as embryotoxin, but not always. So that's why it's quite complicated. And also this is also important because when you have the genotype with a phenotype, prognosis is different, and you will tell the parents differently in both situations.
Thank you so much. We keep talking, but we're running out of time already. We have lots of questions coming up. So Dominique, I'd like you to introduce David, if you would.
Yes, of course. So thank you for this discussion, and thank you, David, because I think you will probably open all our minds for the glaucoma in aniridia, and you have a great experience, and so this is very precious. Thank you very much.
It's such I think I welcome the opportunity to really join all of you. You're such a distinguished group, and thank you, Ken, really for all the work that goes into arranging a program like this. It's really very special, and I admire the work of all my colleagues here, and I'm learning a lot already. The initial presentation here is the typical picture of aniridia, which we're also familiar with the striking but not complete iris hypoplasia. As has already been implied, the iris hypoplasia has named the disease possibly, but it's not the most pathognomonic abnormality that we look for in terms of diagnostic considerations and suspecting a PAX6 defect. There's certainly a number of other causes of iris hypoplasia. And I think I would entertain this picture with you. And this is a child with hereditary aniridia. Both the mother and sons have this defect. And while at a glance it looks normal, there are some subtle characteristics that might help. The most important is, as suggested, is the peripheral opacification, which stains so well. And these children have this, as you would expect. But there are other subtle defects in the iris that are very helpful. And Dominique's pictures, of course, were fantastic and really showed some of these as well. You see characteristically a little narrow ectropion very commonly in this what at a glance might look to be normal. You can see that along it's typically on the nasal border, and you can see the little ectropion. Her pictures also showed in a very nice way these slits in the iris stroma, which are subtle here down to the right, but they're very real and almost constant finding in these irides that appear normal. I think it is true that when you have a relatively intact, and sometimes it's more partial and looking like a coloboma, when there is a partial expression of a mild expression of the gene, then the patients are at less risk for everything, including glaucoma. Next slide. So I've been asked to say a little bit about glaucoma, and so I'll concentrate whatever I'm going to say after this on the glaucoma considerations. Glaucoma related to Aniridia is a reality, and the actual incidence in the disease has been very variably reported, and it probably depends on the cohort of patients that the author is considering. Back in the 18th century, Foster and Harold Falls later on, but you can see incidence 11 to 13%. I am by and large see young patients, and in my cohort of 104 patients, that there was a 30% incidence of glaucoma. I want to have you look at the slide on the right, a beautiful picture of Aniridia, and I hope it shows for all those who are looking at this the subtle defect in the periphery of the cornea. This is the premier pathognomonic diagnostic sign of hereditary PAX-related Aniridia. And this picture, again, taken by Eugene Moll down in Santiago, Chile. And when I saw this picture, I said, I really have to have this because I haven't taken one as good. And you can see the fine granularity of the defect. It stains more intensely along the inner border, and you can see the very puzzling, jagged inner line of the defect. This is sort of the characteristic appearance early in life, and there's often a slow progression centripetally in this defect that we're undoubtedly going to hear more about from Neil, and I look forward to that very much. If aniridic glaucoma is a primary glaucoma, it's not secondary to something else. It's a primary glaucoma and usually acquired, and with clinical onset of elevated eye pressures, most often late in the first decade of life. Congenital glaucomas do occur, but they're quite unusual. And in my experience of approximately now 200 patients with Aniridia, I've only seen 3 patients, and one recently. It can be bilateral, but so it is in the differential diagnosis of the congenital glaucomas, but its expression clinically at that age is unusual. Aniridic glaucoma then, as a rule, is an acquired glaucoma, where the clinical elevation of eye pressure occurs later. So it's a primary hereditary determined disease, and it's acquired. When one does serial gonioscopy on patients of various ages, you see a progression of the angle defect as you see presented in this one slide, starting on the right and going to the left. And what one sees initially is a fine sawtooth attachment of the iris stroma onto the trabecular meshwork, and it's actually variable in different meridians, and the defect is characteristically more severe in the superior angle. But as one goes from right to left, you'll see extension of those little sawtooth attachments up over the scleral spur onto the trabecular meshwork. That movement of the iris is preceded by many little fine vessels that extend from the white border, as you can see it, onto the meshwork. And then if one in somewhat older patients and when glaucoma is present, you will characteristically see movement of that iris stroma up over, and it does suggest movement because you can see separation of the stroma away from the iris pigment epithelium. Later on in advanced cases, that is moved still further, and the trabecular meshwork is completely obstructed. This is the characteristic gonioscopic chain related to the progressive nature of this disease. You can see that a lot has occurred in the left side of the screen, and actually that's the effect of giving a miotic to a patient with Aniridia, where you can, the small stump will shift forward, and you can get complete angle blockage. So that's the picture of this acquired progressive clinical glaucoma. So Ken asked me to say a little bit about a procedure that I was pleased to learn from him that he's found to be very helpful. And when I last reviewed this, I reviewed 160 patients and for what we've called prophylactic aniridic gonio surgery. And the exclusions are aniridic glaucoma. It's not prophylactic anymore if they have established glaucoma. And I haven't found goniotomy to be a useful procedure for aniridic glaucoma once the angle is zipped up. A history of cataract surgery or greater age than 10 years were additional exclusion considerations. So with all those excluded, 55 patients were evaluated, and 45 patients in my series were selected for prophylactic gonio surgery. The inclusion criteria was that they be older than 8 months, and as a goniotomy surgery, you all know why that is, because in a young child, there's no anterior chamber of any significance. And so you want a deeper anterior chamber. And it's remarkable when you're following these patients and look for a deepening of the anterior chamber, how much that has changed from birth till 9 months of age. Also, there has to be a defect that you're trying to help. And so I count on seeing a progressive angle defect for more than 90 degrees. Okay, so I want to tell you a little bit more about these patients. There were 45 patients, 82 eyes, and only 2 patients had the Wagner syndrome, and 37 patients had bilateral surgery, and 8 patients unilateral surgery. And 82 eyes in all. This tells you that number again. Some eyes had more than 2 procedures. I did not use a viscoelastic in doing this surgery, so I didn't have really the opportunity to do it on both sides by and large. And so the majority of the patients had 2 operations. 36 of the number had 1, and 1 patient even had as many as 3. My follow-up in terms of what happened after surgery is quite long, 9 years, and thank goodness there have been no complications related to this surgery. And so what's it all about? Well, Ken has made possible a beautiful video, which I will be showing at the end of the presentation. But the procedure resembles a goniotomy. A goniotomy knife is entered into the eye, passed across the anterior chamber, and the iris stump is separated away from the angle wall. What's different about it is, though, it's not really an incision. And while a goniotomy is obviously an incision in the trabecular meshwork, the first motion of the knife with this procedure is vertical. In other words, you put the tip of the knife next to the stroma and give it a little pressure posteriorly, and it's quite remarkable. The iris will just pop off the meshwork. And it doesn't take any force for that to occur. And what that creates is a little wall next to the left side of the knife. And then once you have that, you can just move the knife along, pulling not or touching the meshwork, but just pulling on that little wall of stroma. And you just go along from right to left and pulling it off, pulling it off, pulling it off, pulling it off, and then taking the knife from the eye. And it's so the actual action point is really quite different than a goniotomy. And we can talk more about that, or I'll have you, of course, to answer questions. So this is what it looks like after you do it. And this is an area where the prophylactic maneuver has been done. And the quite remarkable occurrence after this surgery, and I was highly suspect at first when we started doing this, is that would be the case, is that the iris does not move back. And it's a little bit unexplained. Whatever the phenomena that makes it vascularized and wants it to crawl up the meshwork does not occur after you do the surgery. And you can see a rather sharp edge to the peripheral iris, and as you go from right to left. And the darker kind of pink area, that's the ciliary body band. So it really produces a quite dramatic change in the appearance of the angle, and perhaps that can be related to the good results. So what are the results? In other words, how many of these approximately 50 eyes got glaucoma? Well, those that had at 1 year follow-up, there was no glaucoma at 5 years, 10 years, 15 years. Those patients that have achieved 20 years of follow-up, there has been an occurrence of glaucoma. And all the patients who have developed clinically elevated eye pressures have been able to be controlled medically. I've not done any glaucoma surgery on anybody who's had the prophylactic surgery. So just in summary, there are 45 patients and 127 operations, average follow-up 9 years, no complications, and all the patients, all the eyes, 5 of 82 that developed glaucoma have been controlled medically, and that was later in life. Nobody would disagree with the feeling that if you're going to manage glaucoma in these patients, it's certainly more comfortable doing it as an older patient. So these are my suggestions in regard to this procedure. I would look into it seriously, and Aniridia, it's those patients under 5 years of age. I think the angle has completely been destroyed. But if it's going to be by that age, so it's generally patients under 5 years of age. You need to begin the gonioscopy early and look for the progressive changes which I've described. The surgery is indicated based on the gonioscopy, and I think in all fairness, it takes some personal surgeon preparation for this surgery in terms of your approach to the problem. One caveat is that with a typical patient, young patient with glaucoma, they have an enlarged anterior segment, while these patients with aniridia, the corneas are somewhat smaller, and so the approach with a knife and little subtle things are really different, and I'd be happy to communicate more and provide details with anyone who wants to consider this surgery, which I would encourage. So we really have good fortune to see this beautiful surgery by Ken. And here's the eye is held in position. And in his case, I think he's using a needle, which he's passing across the anterior chamber. And he very successfully will now be removing the iris stroma and what has moved up onto the trabecular mesh. Little vertical movement there I'd like to see. And then he just moves it from right to left, and you'll see it coming off. And it comes off really with no difficulty. And it's a little pressure right there, and it just pops off without an audible pop. And generally, I've just gone from right to left. I suspect he has a viscoelastokin, which gives him a little bit more time than I've enjoyed to go from right to left. So he's going to right to left. And you see that it's exposed a beautiful unobstructed trabecular meshwork. I certainly was very pleased to hear from Ken that his patients are doing well.
Okay. Thank you so much, David. Those are real pearls. Honestly, to hear you talk about this is a real gem. Thank you. Neil, take it away. I'm looking forward to listening to you. This is about aniridia-associated keratopathy. We've got lots of questions. We've got lots happening. Please do start. Thank you.
Okay. Thank you, and thank you, Ken, and thank you, Dominique, for putting this together. I'm very happy to be here and to be part of this distinguished panel talking to you today about aniridia. I'm going to focus on the keratopathy in aniridia, which is a very obvious in certain cases. I mean, this is the first thing that you see when you look at the eye. You see in cases where it's progressed, you see this keratopathy, vascularized tissue covering the cornea. Yeah, I just want to give a quick plug for our cost action, aniridianet.eu. So please go to that website and you can take a look and see some of the activities that the European countries are doing. As Dominique mentioned, some consensus guidelines and also some collaborative projects there. Okay, aniridia keratopathy. Well, as many of us know, the classic AAK is where we see the conjunctivalization of the ocular surface. And this is the progressive ingrowth of the conjunctival tissue over the clear cornea. And this is believed to be due to a limbal stem cell insufficiency in aniridia, unable to maintain the clear corneal epithelium. So what this leads to is corneal opacities and the neovascularization that you see. And so this is what I term the classic keratopathy. However, there are a number of other features that one should also be aware of, which are involved in aniridia in the cornea. And these can be very prevalent. For example, many with aniridia have dry eye disease or signs or symptoms of dry eye. So this is something important to be aware of. Also, tear film abnormalities are also present. The composition of the tears as well are altered. We also have quite often a meibomian gland dysfunction in the aniridia population. So again, that's affecting the quality of the tears. And then it's important to keep in mind, and this is also apparent from a rather young age, it's the chronic inflammation of the ocular surface and the neurotrophic deficit. So this is prevalent in most cases that we've seen, even though it may not become clinically apparent for quite a number of years. It appears to be present quite early in life. Of course, all these conditions of the ocular surface can lead to risks. For example, with keratoplasty or transplantation, high risk that it would fail or be rejected. Also, we see that in cases with a limbal stem cell transplants, these either don't last for very long or they fail. And this is also due to this chronically inflamed and dry ocular surface. Now, here's some images I will present about the keratopathy grading, because it's important to talk about the grade of the keratopathy because it is progressive over time. David Walton talked very nicely about the signs to look for in keratopathy. And so I present here in the top left image, what we call a grade 0 keratopathy case. And this is where the limbal border is still intact. So it's important to check this in the slit lamp, do a careful 360-degree check of the limbus to see if there's any encroachment of the conjunctival tissue. You can see this in the middle image, grade 1. And now this tissue and the vessels along with it start to invade the cornea, but just in the limbal region. So when it remains within about the 1 millimeter from the limbus, this is still grade 1 keratopathy. And interesting to note, we had a little discussion about PAX6 mutations versus other mutations causing aniridia. It seems that the keratopathy will stay between grade 0 and 1 in cases where no PAX6 mutation is found. Whereas if the classical case of PAX6 mutations, it progresses over time. So you can see here on the right, the top right, grade 2 keratopathy, and we've also seen an earlier picture today on this. So this is where the conjunctivalization leaves the limbal region and progresses towards the central cornea, but doesn't reach the central cornea. In grade 3 here, the lower left, we see that the entire cornea is involved, reaches the central cornea, along with the vessels. And in grade 4 here, we see there's a total opacification, there's a thickening of the cornea, and this very thick white pannus. So as I mentioned, this progresses, and it progresses with age. We've looked at different cohorts, and here's it's a summary of left, a Polish cohort, and on the right, a German cohort. And we can see here in the left, children with a grade 1 basically have a grade 1 keratopathy under the age of 20. However, over the age of 20, this starts to progress, and it goes to the other grades, to the more severe grades. On the right here, again, we see children, in this case, grade 0 to 2 keratopathy. Again, after this age of about 20, 25, then it progresses. So, but it's important to also note that there is a variability in presentation of the keratopathy. And we've discussed this as well, variability in aniridia presentation, not only of the iris, but also of the keratopathy. It may be a very mild keratopathy, and it may also progress very slowly, or it could be the opposite. And we have to think about that over 500 unique mutations in the PAX6 gene have been reported thus far. So there's a very large genetic heterogeneity, and this can also impact the phenotype as well as the progression. So this should be kept in mind. Even if you see a very mild case, it does not mean that it's not a PAX6 aniridia. And generally, however, in terms of the mutations, the degree of PAX6 involvement is usually correlated to the severity. So the amount or the part of the gene or that's affected that produces the PAX6 protein is important because it's that reduction in the PAX6 protein that really leads to the keratopathy. So here, just to reiterate that point, we see here on the left, we see 60 eyes with PAX6 mutation, and we see the distribution of the grade of keratopathy. Younger subjects having a lower grade, and the classic, as we progress over the age of 20, it goes into the central cornea or grade 3. And on the right here, we see 10 eyes, and these are rarer cases, but there are no mutations in the coding regions of the PAX6 gene. And here we see that the keratopathy does not progress beyond grade 1. So it's important to look at the mutations, not only in PAX6, but also in the flanking genes, such as ELP4, DC, DC1, genes that are regulating PAX6 as well. And because if the mutation is there, it could mean that we have a lower grade of keratopathy and a slower progression, and a better visual acuity. So this table here summarizes, in some cohorts we've seen, the prevalence of the different types of mutation. So the mutation type here in the first column, and the prevalence. We see here, for example, with non-coding mutations, which is only in about 10% of cases, we see that we have a very mild phenotype of the keratopathy. With missense, it's similarly mild missense mutations. However, with the majority of cases, 70% of cases, have premature termination codon or C-terminal extension mutations. And in these cases, it's the classic aniridia, which is age-dependent, which progresses, as I showed, over the age of 20, starts to reach the central cornea. And then we have a group with 10%, and these are chromosomal deletions. So Hannah talked a little bit about this. So entire PAX6 chromosome can be deleted, as well as neighboring chromosomes. And here we have, for example, Wilms tumor gene, or some of these other genes that I mentioned here. And those tend to be a very severe form of keratopathy at a rather young age. So if we're thinking about the prognosis in terms of these different mutation types, we can see that in the non-coding, we have relatively preserved vision and rather good prognosis. However, when we come to the PTC and CTE mutations, the classic aniridia, it is a mild keratopathy in childhood. However, this progresses during the teenage years and covers eventually the whole cornea. And the chromosomal, on the other hand, gives a generally poor prognosis because we have an aggressive keratopathy at a young age. So question being, how early does the keratopathy start? Sorry, just turn that off there. Yeah. So the limbal niche is known, well, there's a couple of publications that have shown the limbal niche to be not developed fully prenatally. Instead, it develops postnatally. So only after eyelid opening. Can you turn that on? So this could explain the delayed onset of keratopathy, because the limbal stem cell niche isn't completely fully developed in utero. It could still be undergoing development after birth. So In the case, if we talk about the most common cases, PAX6 mutation, 70% of cases, these are leading to the PAX6 protein decay. What we see is there is an early dysfunction of the stem cell niche. We note in infants that already this is apparent, even though it may not be clinically apparent. We see that the corneal epithelium is already affected in these cases. There is some conjunctival cell islands. They have the inflammation and a nerve deficit that's already present in infancy, and this progresses, as I mentioned. Final point here to keep in mind, there's ocular surface damage and dry eye signs in aniridia, and these are, for example, ocular surface staining. We talked about fluorescein staining, reduced breakup time and reduced tear production, and these can become apparent after the age of 10 years. And they are not mutation dependent. So this is across the board in aniridia. At least this is what we see. So it's important to keep an eye on the ocular surface and the dry eye status, because many people with aniridia have these already in their teenage years. So with that, I'd just like to acknowledge my colleagues as well as the cost action. Thank you.
Thank you so much, Neil. Thank you. You better answer that question. It might be your wife telling you off for not doing the dishes. We got lots of questions. We're running a little short of time. However, David, people are asking, I just want to let you know, from the Menti question, we asked how many people had done gonio surgery in aniridia. Only 4% of people listening have actually done gonio surgery in aniridia. So people are asking, what knife do you use? What's the earliest you could do it? How do you know it's worked? Can you briefly answer those three questions? What instruments do you use? How do you? What's the latest you can do it? And how do you know if it's worked?
Well, they're very good questions, and so the story, I guess, is in the details. There are a lot of different goniotomy knives, and I think it's probably useful to use one that you're familiar with. I don't know the percent of people who use what. I think a needle knife is often used. I think it's possibly not the best. And I like a knife that has a slight taper, because maintenance of the anterior chamber during this procedure is a must. So I think you want a knife that has a slight anterior chamber. I also like a knife that's not too sharp on the end. Occasionally you'll just touch the meshwork when you do that initial pull of the iris off the meshwork. So you don't want a knife that's terribly sharp. And on the other hand, it's nice if the knife is a little bit broad at the end, because it allows you, as with the goniosneaker lysis, to give that initial little pull to pull the iris off. So there are a lot of knives out there, and I would recommend a really excellent knife, which I'm highly biased about. It's available with stores. It's a special instrument, and I'll give you the reference number. It's a special instrument SP7622233, and
David, I'm going to interrupt a little bit because we're running out of time. Can you answer very briefly, how do you know it's worked?
Well, you know it's worked by one when you have the opportunity to do the gonioscopy, but that's not the metric. The metric is following the eye pressure, and when you have the opportunity, you can look in the angle to be sure that it's still open. But in the long run, following these patients' eye pressures has been the metric which has shown that at least these patients have not gotten glaucoma, but also recognizing that the incidence of that in the disease is probably no more than 50% overall. So I don't know that one can be absolutely confident that what you did doesn't work, but I think it is reassuring that in such a large cohort of patients that the results have been so good. The answer is follow the eye pressure.
Okay, we're going to move on because we're running out of time. I think I'm talking next, Dominique. Is that correct? I think it is. Just because of time, I'm just going to start.
Yes, we will talk about cataract and in aniridia, and we have a lot to see. Thank you, Ken.
Okay, so I'm now going to use. We're going to do Indonesian language because we've had a lot of people from Indonesia listening. If you're interested, there's this review paper that we did, which is open access, which covers a lot of what we've talked about. Look, in aniridia, the cataract can be posterior polar, posterior subcapsular, posterior polar, anterior polar, and this is what it looks like. This is the OCT showing the foveal hyperplasia that we were talking about. You can have iris presence. When you have an anterior polar cataract, it can be pyramidal. This is what a pyramidal cataract looks like. This is somebody who had a deletion, which included WT1 and PAC6. This was really affecting this child. And people were reluctant to operate because psychologically, you've got no iris to protect you if you make a mess of the openings of the bag. But you can do that. You just have to stick to your, use a heavy viscoelastic. This is a video showing that I've already done the anterior rhexis. The anterior opening must be smaller than the optic. It's never more important than in aniridia, because if that optic comes forward, it's going to hit the cornea. So you've got to be exact. And you'll see that I'm just going to rotate this in. Try and use a 3-piece lens because you want to keep that bag stretched. The 1-piece lenses allow the bag to contract. People talk about the artificial iris. There are lots of artificial irises that are available. There's also the colored lenses. I'm going to talk about those in a minute. This is keratolenticular adhesion or Peters anomaly due to aniridia. And in this case, to improve the vision, what I did was I took the anterior capsule away. I've been left with a big opening. I did a posterior rhexis. There's a bit of vitreous loss, so I did some vitrectomy. I used a 1-piece, and I used a 1-piece here because I have to do posterior optic capture. It's not enough to put this in the bag because the anterior opening is much smaller. Now, here's a situation where if you try to put an iris, artificial iris in, you are risking glaucoma, corneal decompensation. The only other thing you have left is even if you sew it into the sclera, you're risking those. Now, this is how I do my optic capture. I use 2 instruments. You'll see me swap instruments in a minute. And I just rock the lens into place. And you'll see I'm pushing it down and back, capturing the edges, and there we are. It's now captured. Now, I don't use artificial iris. I don't use colored lenses that have an aperture in them because I find that you get this chronic, almost leakage. The eyes never look quiet. And I haven't done it for 20 years. So this is after optic capture. It's another case that I did. I want you to notice that the lens epithelial cells, they grow back. And when they grow, they don't go into the axis, but they act as your diaphragm to stop light bothering the child. So that's why I don't put artificial iris in. I really don't think it's a good idea in children. And I don't operate on adults anymore. So for children, I don't use it. Dominique, actually, I'm going to, for the sake of time, introduce Hannah. Hannah, before, as you get started, we put a question out and said, how many people had heard of atalurin? And which is what you're going to talk about. Do you want to share your slides, Hannah? 72%. 72% of the audience have not heard of atalurin. So I think this is going to be eye-opening, if you pardon my pun.
Good.
Thank you very much. So in a nutshell, I'm going to discuss what atalurin is and its mechanism for patients with aniridia. And it's currently has been in clinical trial, and we're awaiting further information about the outcomes of the study. So this was just a reshow of our genetics. In the case of atalurin, which I'll describe, it is specifically a therapy that has been investigated for patients who have mutations only within the PAC6 gene. So for any patients with a chromosome abnormality of any kind, or for certain types of variants inside PAC6, this is not an option. So I'll discuss exactly which type it is relevant for, and this is where that second level of genetic testing, once you've ruled out a deletion that could put someone at risk for Wilms tumor, that's where that becomes relevant to say, well, what is the mutation in your patient's IPAX6, and is there a future opportunity for therapy? So Adeleron's mechanism really comes back to our protein translation. So in this diagram, showing you your mRNA for PAX6 and your ribosome clamping on here in blue and purple. And the green is demonstrating your protein getting built in a normal situation. But what we have to think about is the nonsense mutation. So what about when you can't create an entire PAX6 protein, thus leading to aniridia? So the nonsense mutations are the ones where a premature stop codon gets inserted due to a substitution of an incorrect nucleotide. What happens functionally when you have a nonsense mutation is your protein starts to grow, but your stop signal happens very prematurely and you have a shortened protein. Depending on where this occurs in your mRNA, this protein will be degraded. And that is where you can get a lot of the functional problems in the expression that we see in our patients when they have complete and partial aniridia. What Adeleron is something called PTC read-through. This is the actual mechanism of this biomolecule. So PTC is the shortened version of saying a premature termination codon or that nonsense mutation, the one that shortens your protein completely. And what Adeleron as a biomolecule does is it promotes the ability of the ribosome during that process to actually read past that premature stop location. And this, while it's discussed as a possibility for aniridia, it's actually can be applied widely to lots of genetic disorders because Adeleron as a molecule is not specific to PAX6, it's specific to a nonsense mutation. So you can imagine as a nonsense mutation is often a major player, not just in PAX6 because it's one of the most common types of intragenic PAX6 mutation, but certainly for many other disorders. Another important component to think about with aniridia or Adeleron and how does it work really comes back to our genetic code. So our genetic code is redundant. We have 20 amino acids, but we have 64 codes that allow it to be generated. And so what Adeleron does is it kind of harnesses this inherent redundancy, where if you think about the stop codons, they're very similar to what other amino acids are coding for. So what it actually does is it makes it less sensitive to the last letter. And so you may instead be able to read past it and flex in a separate code at the third position to insert a different amino acid. It may not be the correct one, but it doesn't matter because what matters is that you're reading through where it would have stopped prematurely in your patient. So this was an example from Adeleron from the pharmaceutical company website showing you interference, but I'd like to think about it another way. When I think about explaining it to patients and what we may consider is think about a stop sign. It's inserted prematurely. You're driving in a car, you would stop here. But what Adeleron does is it kind of fades that away. Doesn't take it away completely, just makes it less sensitive, allowing you to drive past it and try to make a longer protein. So that's one way to think about it as well. When we think about its application in aniridia, Dr. Gregory Evans' group in British Columbia had published a paper in 2014 using the naturally occurring aniridic mouse model. Now, in the mouse model, they have a lot of retinal abnormalities and lens abnormalities, so a little bit different than the human phenotype. But postnatally, a specific formulation of Adeleron was able to reverse the retinal and lens abnormalities in the mouse model. And quite shortly after, it was a matter of weeks of postnatal. So when they started thinking about applying this to children or adults with aniridia, there was a clinical trial called STAR. They did a randomized placebo-controlled study, and the endpoint was specifically, can we increase the maximum reading speed on acuity charts in children greater than 8? And does the application of Adeleron over many weeks' time allow this to be increased? And we're still waiting complete results, but they found that while it was not statistically significant, there was a very positive trend. So we're still awaiting long-term data and the next steps of these trials to see how it may be applied in aniridia. So, of course, we're anxiously awaiting that for our patients. But without doing further interrogation of the PAX6 gene to find out exactly what type of mutation your patient may have, if Ataluren does progress to clinical trial or potentially the hope would be a true therapy, you may not know if your patient's eligible. So that's yet another reason to consider genetic testing. Thank you.
That was fantastic. I have to tell everyone, the first time I heard the Ataluren story, I nearly fell off my chair. David, were you aware of Ataluren?
I was aware of it, and so I've been following from a distance. And it is difficult to learn all of that. One might know about the results of the studies. That there have been clinical trials, and but it's a complex story of drug use and drug trials and drug pharmacy competitiveness, and it's a complex story. But the final story certainly is not out yet.
No.
Yeah. I had a question because it's very interesting, of course, for Ataluren, but the question maybe to Neil. All over the world, it's very difficult to find. Not all the patient can be access to testing, genetic testing. So, what do you recommend, Neil, for that? Because it's not easy.
Yeah, no, and I think again it comes back to the telltale signs here. If we have, I mean, if the person is old enough that this keratopathy has progressed past the stage 1, you'll be able to see that on the slit lamp. So then you'll have quite a good indication this is a progressive keratopathy. So, and that is the classic Aniridia, and these would be the ones that would be eligible for this.
Right, and to prevent, Ken, just a question, Ken, to prevent Aniridia related keratopathy, what is your advice for that?
Oh, I'm glad you asked that. I am very aggressive as soon as I find a child with Aniridia to keep the eye wet. You have to keep it wet and non-inflamed. So I do artificial tears, which are preservative-free. I use punctal plugs. I will use Restasis, which is cyclosporin available in the United States. You know, you can get cyclosporin in other parts of the world. My big worry is when you get glaucoma with these kids. You see, this is why I turned to David's work, because when you get glaucoma with these kids, you're now giving them a back in their drops for their glaucoma, benzyl alkonium. And that really makes things worse for these kids. So I try to use preservative-free eye drops, but the prophylactic goniosurgery, I think, is something that's important. What do you do, Dominique? What is your?
Well, the aggressive tear film substitute is very important. Also, what is important is preservative-free, of course, and that's important because patients don't know usually. And also, I just think that we have to avoid also contact lenses, because contact lenses just increase the problem of the keratopathy. And even if there is some colored and contact lenses, I think it's a contraindication for me. It could be scleral lens for very severe keratopathy, but I think it's very important to avoid usual contact lenses.
I have just a point here. Because a lot of people that may be watching right now are using autologous serum drops. And so what is your feeling on this? There was a study done some years ago showing that in the short term, at least, it can give temporary relief to some of the ocular dryness signs. Ken, want to say?
Dominique, do you want to talk about that?
Yes, I think autologous serum is a good alternative. It's very difficult in young children, of course, because you can't ask the children to be to have blood every month or every 3 months. But it's a very good alternative when you see the keratopathy is going to be in a severe form. So before pacification, I think it's a good thing if it's for at least, I should say, more than 12 years old, because for children it's very, very hard, I think.
Do you ever use maternal serum? Do you ever use maternal serum?
Oh, maternal serum? No. Usually it's autologous serum. Right.
Yes, I have used that in other situations like graft versus host disease, but I have not used it in Aniridia. I have now got the setup, or I'm about to get the setup where it's easily accessible. So I do agree that it's worth doing. Before I come back to David for another question and to Hannah, Neil, there's a question. Does the staining of the pannus give you any information about how severe this is?
Yes, yeah. The staining. Yes, the staining of the pannus. The more, of course, we are seeing the staining. Yes, this is because the epithelial function is no longer, and the epithelial cells are no longer functioning, and then we have instead the conjunctiva. Yes, so it's related to the severity.
Just a clue that I learned: if you put the fluorescein in the eye, we always just look at the cornea. Look at the conjunctiva. If the conjunctiva is staining, it means that there's so much chronic inflammation going on that even the goblet cells are being affected. And those are the ones where autologous serum, steroid, I will use FML or Lotepred to try and calm everything down. There's questions coming from all over the place at the moment. David, question to you. Have you ever done a trabeculectomy in a patient with aniridia with no iris, or do you always use a tube when you want to control the glaucoma when it's sort of not medically controllable?
Well, that's a very good question. And what types of alternative surgery do you use? Trabeculectomy is a very good operation for aniridia. I approach that with the same optimism that I might a child of a similar age. There's one caveat. In doing a trabeculectomy or any other glaucoma procedure, you cannot allow the anterior chamber to become flat. You cannot allow the lens to come up and touch the back of the eye. So patient cooperation, parental support is essential. These patients must be followed daily after surgery to assure, with the opportunity for the surgeon to return the patient to the operating room and reform the anterior chamber. This is absolutely essential, and I've had too many patients who have come after glaucoma filtration surgery with completely opacified corneas, and they are permanently opacified if the lens corneal touch is allowed to occur. So yes, trabeculectomy is a very good operation. I use mitomycin C, and I approach it with a lot of optimism for a good result.
Yes, I agree.
What about, sorry, go ahead.
I agree, and also I try to avoid laser procedures, and I just prefer trabeculectomy, of course. I think it does better.
Do you use tubes? Do either of you use tubes?
Not for aniridia. I think it's. I use tubes for some congenital glaucoma, but not for aniridia.
So this reminds me. There are a lot of people. Most of the people listening are healthcare workers, but I know that because of your associations, Neil and Dominique, that there may be some parents listening. It's very important, parents, that you communicate with your local provider. If we've said anything that's different from what's happening, we haven't examined your child, we haven't looked at your child, please communicate with them. If there's anything that you hear that is slightly different to what might be or might have been done. We don't know what the circumstances are. So that said, let's just go to Hannah. Hannah, for me, the thing about atalurin is, you know that we've had some patients who we don't know what they were on, and they've been in the trial at another center. We follow them up. To me, Neil, Dominique, I think I know which kids were having it because their ocular surface improved so much. Now, this is just purely speculation. I'm dying to know if I was right, but it seems to me that that would be the one place where if we could arrest the ocular surface disease, atalurin would be worth it. I'm not worried about the vision. The ocular surface is the thing that gets these kids at the end of the day, right?
I think you're right. I agree. I think two things get them in the very, very low vision is first keratopathy, and the second one is glaucoma. And sometimes you can see there is some phenotypes with glaucoma and some others with very severe keratopathy. So I'm sure if we can clear the cornea, it will be a very good thing because we can keep the children with the best vision.
Yeah, I agree completely, Dominique. And I think it's important to keep in mind that we don't yet know that the stem cells are completely gone and they're completely dysfunctional in aniridia. It could be the case that without the support of a healthy ocular surface, the stem cells can't function properly. So if we can try to take care of the ocular surface, then we could perhaps prolong the period until it progresses.
True.
Hannah, go ahead.
When we look at the original work that was done by Gregory Evans' group, when they were trying to experiment with the different types in the mouse model to see what kind of effect they would get, depending on the formulation they used, they actually increased ocular surface irritation. So that's what led to the last formula that actually had the improvement, was a different combination of topical drops. So it may actually all be related, and we'll have to see when the results come out from the clinical perspective.
So we're running out of time, but there's some really interesting questions. David, in aniridic glaucoma presenting with a superiorly subluxated lens, cataractus lens, what would be your procedure of choice? They're not controlling the glaucoma, the lens is subluxated up, it's cataractus. What would you do? How would you handle this given all your vast experience?
I think it's very difficult to really comment on what's best for an individual circumstance. The examination is so important, the vision of the eye and so forth. If the lens is threatening the back of the cornea, then the lens has to be removed, and you can deal with the glaucoma secondarily. One additional note is the tubes were mentioned, but without too much comment. And trabeculectomy is a wonderful operation, but it does not work well in young children. In other words, if you have a 1-year-old child who needs glaucoma control, that may not be your best choice. And a tube for a child such as that would be a much better choice. And then with the eye, if in fact you lose control later on, you could do a trabeculectomy at 4 or 5 years of age. That would be a much better choice at that time. So tube is a valuable alternative, but I save it for very young children who have this problem.
And I think that's fantastic. I mean, so we're running out of time. This is what I would like to do. I'd like to go around the panel, and if you have one pearl to give to the audience, what would it be? I'm going to start with David. I'm going to start with you. What's your one pearl on aniridia? You could talk for hours. Your experience is enormous. What's the one pearl you'd give them?
Well, there's so many pearls, and all these presentations today have been so excellent. It's really difficult to really add to it. Diagnostically, clearly, identification of the peripheral corneal opacification is really important, and fluorescein has really helped. And I think that really takes away all the mystery of diagnosing hereditary aniridia or not. There are so many other lookalikes with iris hypoplasia that's really a very important diagnostic step. After that, I would encourage measuring the eye pressures. I mean, that's rather than let it be a phenomena that you're just identifying later in life. So anything more I might say to just echo what my distinguished colleagues here have already described.
Okay, Dominique?
Just one pearl. It's a panocular disease. It's very important to make the diagnosis very early and to recognize for some incomplete forms. And so if the diagnosis is made, so you can prevent or try to prevent ocular surface and glaucoma.
Neil?
I would say, first of all, it's important to know about the specific type of mutation. And secondly, also that don't forget about the inflammation and dryness of the ocular surface.
Great points. Hannah?
I think if you are able to get genetic testing for your patient, if you can only have one test, you would get that chromosomal microarray. You want to be able to rule in or out the risk for renal tumor, and that same test may allow you to rule in or out phenocopy, as FOXC1 was mentioned earlier, where it can really be some other anterior segment signs that pull you away from your classic phenotype, you can get that assessment by the microarray. If that's the only test you can get, that's the one I recommend.
So for me, it's if you have glaucoma, it's important that however you measure the pressure, that you do it consistently with the same instrument, and measure the axial length, because you may get an artifactually high pressure or a low pressure, and if the axial length is getting bigger, you haven't got control. That's my one pearl. I want to thank everybody. I have a couple of thank yous to say as we get to it. We have lots of questions. We will answer those for you guys. I'm just going to share my screen again, and just a few housekeeping issues that I would like to talk about. We're now going to go to Portuguese, because apparently a lot of people from South America listening, so hopefully there will be Portuguese there. A WSPOS Facebook page, please join it. International listserv, David Granite's listserv, dgranite@ucsd.edu. Email him. Become a member of WSPOS. It's free. There's the web page. There are new activities going on the Facebook page. We have mentors. Dr. Haber here and Dr. Claudia are two of our mentors. We're starting units where we're going to talk about how to review a manuscript, ocular genetics, plenty of information for you to get involved in. The thank yous. Cannot do this without NTOD. Thank you so much for your support. Cannot do this without Dara McCafferty and Akila Charia. Go to the YouTube channel. Please subscribe. There's be more videos coming. Remember, next week, number 15, pediatric glaucoma. We have Nicola Freeman, Peng Kaur, Roberto Caputo, Alicia Serra. And on that note, I want to say a big, big thank you to all the panelists. Thank you so much for being with us. And thank you, the world. I hope to speak to you and see you all very soon. Thank you so much. Hannah, Neil, David. Do you want to say anything, Dominique, before we go?
No, it was a great, I think it was a great discussion, and I'm really happy all these people with us. And so be with us with WSPOS. It will be great. Thank you for all.
Thank you, everybody. Take care. Take care.
Thank you.
Thank you.